So we have this big update in the vaginal estrogen world just very recently. A couple of weeks ago, the FDA has made moves to remove the black box warning from many estrogen containing products, including vaginal estrogen. This is fantastic because the black box warning on vaginal estrogen was slapped on in 2003 when the Women's Health Initiative published some findings, and then a class-wide boxed warning was added to all estrogen products across the board, when in reality, the risks that we saw increase with that trial were actually pretty isolated to oral estradiol, specifically when paired with medroxyprogesterone acetate, certainly does not apply to vaginal estrogen. So there's been a lot of effort made by different societies and individuals really advocating over the years to have this black box warning removed, really so that more patients can have access to care. It's removing barriers in terms of clinician levels of comfort and prescribing vaginal estrogen. So this is very positive, okay? So as of November 2025, the black box warning should be going away. New labeling is going to distinguish system. This is what they're saying. Everything is in the works while we're recording this, so probably by the time this is published, we'll have more up-to-date information. But as of now, the new labeling should distinguish systemic versus local estrogen therapy. Products are going to retain the non-boxed risk language for systemic estrogen, especially with regard to like endometrial cancer risk with unopposed estrogen, and account for individualized cardiovascular and breast cancer risk as well. What's great about this is it really recognizes that low-dose vaginal estrogen has such limited systemic absorption and such a great safety profile. So generally speaking, the professional society responses have been uniformly very strong, very supportive in this move, specifically with regard to vaginal estrogen box warning removal. Menopause Society, ACOG, AUA, nurse practitioners, and women's health, they're all very much in favor of this change. And this is just specifically to vaginal estrogen. There are still some nuances with regard to systemic estrogen, particularly related to the formulation and the route of administration and the timing of that initiation. We have plentiful evidence that shows the very low risk of the vaginal estrogen, namely because of that very minimal impact on systemic estradiol levels. We have clear data showing that there's no increased risk of breast cancer, no endometrial cancer risk being elevated, no increased incidence of stroke, venous thromboembolism, or mortality. There's growing evidence actually of safety and even survival benefit in women with breast cancer or who have survived breast cancer with vaginal estrogen use. So that's really exciting and really fantastic to see, not just for quality of life, but also mortality benefits. Oh my gosh. This study, the hot off the press study from earlier in 2025, was one of the big studies that actually helped to really support this move by the FDA. And the advocates of removing this the black box warning pointed to this study and many others, but this is one of the newer ones that came about specifically on breast cancer patients. So they looked at 18,620 breast cancer patients over the age of 65. And this is from 2010 to 2017. 800 of these patients were using vaginal estrogen and 17,000 were not. It's not very many using vaginal estrogen, but the overall survival showed to be significantly higher in the vaginal estrogen users. And breast cancer specific survival was also improved. There was a duration effect, they called it. So over 7 years of use, the greater survival benefit. So again, another reason to stay on this treatment. There was a hormone positive subset. They broke that study down a little bit farther. So hormone positive breast cancer patients had an overall increased survival as well. So that's just a little bit more of a specific population. So super exciting, really encouraging study. All right, so creams, inserts, rings, and oral tablets, and we're going to get into each of these individually here. Estradiol 0.01% cream. Brand name is Estraze Vaginal Cream. Don't prescribe Estraze, just prescribe the generic version. It's going to be a lot cheaper for patients. So this is going to be most affordable option in most cases. Insurance companies generally will cover this. If they don't, you can use a GoodRx coupon and make this much more affordable for your patients. Pro tip, I usually have my patients throw away the applicator and just apply about this much cream on their finger and then apply that cream intravaginally and then around the external vaginal labia anywhere that they're experiencing vaginal dryness or tissue change, right? And the key here is to rub that cream in very well because the number one complaint with the vaginal estrogen cream is that it's messy. So if you use the applicator, it just shoots a big glob of cream up into the vagina and then it's messy and goopy and falls out and nobody likes it, right? So they stop using it. So rubbing it in really well, I say it's skincare for your vagina. Just act like it's sunscreen or moisturizer and you'll be good. And most people, when they do that, stick with it. So that's great. If the cream is just not going to work for your patient or there's another reason why you would want to use the vaginal tablets, you can prescribe Vagifem, Uvifem, which is the generic of Vagifem, or even Imvexi. Imvexi, I've never had success getting insurance coverage for. I usually will just do Vagifem or Uvifem, but similar product. So it's just a small little estradiol tablet inserted vaginally. You can use the applicator, you can use your finger. Pretty localized effect for the internal tissue, so really good for women who are experiencing more like deep sensation of like dryness and tearing or painful intercourse. Some women are just like, it's easier. This is an easier option for me. I just want to do this. So that's fine. Similar efficacy. Vaginal ring is another good option that's really low maintenance. It's the E-string. This is really good for the patients that might not have the best compliance. It can be left in or taken out during intercourse, whatever they prefer. Lasts about 3 months. So again, conjugated equine estrogen cream, older formulation, not used very often anymore, just like the oral CEE or Premarin, oral Premarin. It's made from conjugated equine estrogen, pregnant horse urine. It is compounded in an alcohol-based formula, so it can be really irritating to some people. This is just less commonly used now. But if you want to, for some reason, you can prescribe it using this formula here. And vaginal DHEA is another option. Brand name is Intrarosa. The mechanism here is that the DHEA, it's a precursor hormone, right? So it'll convert to estrogens and some androgens. Really good for women who are experiencing pelvic pain. So if there's GSM and painful intercourse, DHEA can be a really good option. It's really hard to get insurance to cover Intrarosa, so your best bet would be to have this compounded if you really wanted to go with the DHEA option. And you can use the same prescription here on the right for that compounded DHEA as well. Okay, some people also like to use vaginal estriol, which remember is the weaker form of the 3 estrogens that we produce. Used to be a super popular option. It was often combined, and still is, combined with estradiol or E2 to form a bi-est cream. This is not included in the AUA guidelines, probably because it's only available compounded in the compounded formulation. If you want to prescribe just estriol, you can follow this formula for intravaginal use, vulvar and vulvovaginal use. For most patients, I think that they can benefit from vulvovaginal use just because it's very rare that just GSM is isolated to the vaginal canal. It usually tends to be a little bit more diffuse, but individualize the therapy. Side effects of the vaginal estrogens, very minimal. Again, absorption, very rare. Sometimes for patients who have very dry atrophied tissue, there'll be a transient rise in those levels. And that's because the medication just gets absorbed so quickly and systemically through those thin tissues. But once we start restoring the elasticity, the collagen, that tissue integrity, that systemic level will return down to normal. And it's not like really high levels, but sometimes in really sensitive patients, they might notice some breast sensitivity, maybe some nipple sensitivity. I have seen that before. So I just counsel patients, you might experience this, but probably not. And we're very confident based on lots and lots of research that systemic absorption will go down. It's very transient. Systemic safety considerations, there's zero evidence of increased risk of breast or endometrial cancer, cardiovascular disease, or venous thromboembolism with low-dose vaginal creams. This applies to all of the different formulations. Occasionally, some women, especially if the tissue is really sensitive or they just tend to have reactions to different products, might have some irritation, might have some discharge, and rarely, especially for women who do tend to be more predisposed to candida infections, they might notice an initial increase in their risk of yeast or the incidence in yeast infections. And that might prompt them to be like, oh my gosh, I don't want to do this because now I'm getting yeast infections. It can't be good. But it's just that it's because we're shifting around the microbiome and the pH, and there are things really changing in that microenvironment. And over time, obviously, we treat the yeast, right? And I really encourage them to stick with the estrogen. And over time, as we restore that tissue integrity, the risk of those secondary infections really goes down. Again, endometrium is safe with these. Okay, so this is a little timeline to kind of demonstrate the research that has been done on vaginal estrogen and a reduced risk of recurrent UTI or use of vaginal estrogen for UTI prevention. In 1993, we had our first randomized controlled trial. This included 93 postmenopausal women with recurrent UTI. They were using estrogen creams versus placebo, and then nothing really happened. So then in 2013, a big systematic review was completed, including 44 studies. I guess this was a landmark study. There were smaller studies subsequent to the 1993 study. And then in 2013, they did the systematic review on 44 small trials and confirmed that vaginal estrogen did indeed reduce UTI recurrence. Unfortunately, because a lot of the studies that had been done, the randomized controlled trials, had used different formulations of the product, they still couldn't determine if there was superiority between different formulations. Then, between the years of 2013 and 2020, there were some meta-analyses that were done, provided more encouraging data, found that, this is interesting, they found that oral estrogen tended to be ineffective for recurrent UTIs. So this led everybody to further consider the low-dose topical application specifically for this indication. And then in 2022, the society guidelines had a big update and started really widely recommending low-dose vaginal estrogen for perimenopause and postmenopausal women with recurrent UTIs, unless contraindicated for some reason. And now the consensus today is that this is a safe, effective, and evidence-based strategy for UTI prevention. It's fantastic. The mechanism is very similar to treating the symptoms associated with GSM, right? So restores that vaginal epithelium, normalizes the pH, reestablishes that lactobacilli-rich microbiome. So this is important. Many older women do suffer from recurrent UTIs, and it actually can have a big mortality impact for a lot of elderly individuals. Many older women have serious complications due to urogenital sepsis because of recurrent undertreated UTIs, and is totally preventable. We have the tools, and they're very safe.
Start your 7-day free trial at KarazianInstitute.com if you're a licensed healthcare practitioner ready to evolve your functional medicine practice. Explore over 300 hours of clinical training, masterclasses with leading functional medicine clinicians, and certification pathways. Or check out the Academy of Functional Nutrition and Lifestyle Medicine at afnlm.com. Whether you're on the path to certification as a functional nutritionist or simply want to optimize your own and your family's health, our skill-building approach builds real-world competence from the ground up. And lastly, if you're dealing with chronic health challenges, visit drknews.com for self-paced courses that help you understand and address fatigue, brain fog, autoimmune conditions, gut problems, and more using evidence-based approaches. The content on this podcast is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult with your healthcare provider before making any changes to your health regimen. Thanks for listening, and don't forget to subscribe and share with someone who might benefit.